So let's talk about bone density diseases. Osteopenia. Osteopenia is that you'll have inadequate density of the low density of the bone, but not so much that it's going to affect your normal daily well-being. Okay? The thing is that we don't want this to progress into something more sinister as osteoporosis. So they do at 50 years old and more, especially on women, they're going to do bone density scans and calculate what your bone density is. There's numbers. You don't have to worry about the numbers, but there's numbers that'll say she has osteopenia. Now this is good because this is reversible. We can change this. Okay? What we don't want is it to go to osteoporosis where it gets even worse and now becomes irreversible. Okay? When I mean by irreversible, we can't fix what the damage was already done, but we can stop the process from getting worse. The people that are at risk for this, more women than men, because of the women than men, because the estrogen. Estrogen is important to keep the osteoclast activity toned down. Once we lose that during postmenopausal states, now the osteoclast activity, well, the osteoclasts say, geez, nobody's watching us. Estrogen isn't watching us. So we have more fun and we can start eating away at the bones even more. So estrogen is kind of like the parent, right? Toning them down. Whites have it more than blacks, and a slim frame versus an obese frame. And I'm not encouraging people to become obese, but the reason why on this is because we know that if you have weight on your bones, that's going to put more mechanical stress on your bones, which means that your bones are going to get stronger. It's going to create more osteoblast activity, put more calcium in there. But if you have less weight on your bones, a slim frame, then there isn't much weight bearing on those bones. So you're not going to get that mechanical stress on your bones to create stronger bones. So we have osteoporosis. And this is bone loss where you're going to get some kind of, it's going to affect your normal function. All right? At this point, it's irreversible. We can stop it to getting worse or continue, but we can't fix what osteoporosis ended up doing to the bone. Okay? You get more prone to fractures, right? Hip and vertebrae are the most common that you see fractures over there. And the compression fraction of vertebrae is kind of like, if this is your, I'll show you a picture of it, but basically you have all your vertebrae and all the weight is going to crush it. It's going to compress the vertebrae. And you can't really do much about that. You can't put the person in a body cast. It's not going to happen. All right, so I'll show you pictures of that. We do note that about 1/3 of women over 65 suffer from some kind of fracture that is due to osteoporosis. Okay? We get a primary osteoporosis or secondary. Primary means that it's coming right from the bone. Okay? And the most common reason for this, most common reason is happening in the postmenopausal female because of the estrogen. But we also have secondary osteoporosis, secondary meaning that it's caused by something else. And we can have hyperparathyroidism. Think about it. This is where you got to put your noggin together. You have an increased amount of PTH coming out of here, which means what's going to happen to the activity of osteoclasts? Does it go up or down? It goes up. If it goes up, then what happens to the density of your bones? It's going to, now you got to think, like little Pac-Men, right? They start chomping away at your bone to put the calcium from the bone into the blood. So what's going to happen to your bones? Density decreases, osteoporosis. Okay? That's what happens here. If you have corticosteroids, prednisone, that'll also deal with this. We'll get into Cushing's syndrome later, but that's an increase in cortisol. Veteran people in bed for a long time, they should be walking, but they can't for whatever reason, so there's no weight bearing on them. So these bones get less and less dense. Vitamin D and so forth, okay? Or decrease of vitamin D. So here, see, it looks like a loofah, doesn't it? It looks like spongy bone. So that's your vertebra. See how it looks like this? So here's a normal bone over here, and here's one with osteoporosis. See the density? It goes down. Here's what it looks like here, the spongy bone. All right? That's a compression fracture. So because your vertebrae look like this, all the weight can crush that. And that's what happens. So now you understand what happens to grandma when you see her. She becomes shorter. Right? Here's grandma at like 20 years old. Here she is at 60 years old. Here she is at 80 years old. She gets shorter because the vertebrae compress. It may cause back pain, but that's why she has a pudgy belly there, because the intestines doesn't get smaller. So now you're creating a smaller abdominal cavity for the same amount of intestines that's there. It can't stay there, so they have this pot belly. That's too easy for me to do. It's bad. I eat too much food. But that's what's happening over here. Does that make sense? Okay? They get more fractures, and that means they're going to get more hip replacements. All right? Questions on that? All right. So you do this DEXA scan, right? That's a bone density scan, and that's what they're going to check for. The heel and wrist are the easiest things to check for. So the wrist and the heel, the ankle, and the wrist. They're good, but if you can, and they can, the hip and the spine are the more accurate things, and they test for bone density there. And the treatment is just continue doing weight-bearing exercises. Makes sense, right? Give it more, the bones more stress, mechanical stress. Bisphosphonates, the same thing as Paget's disease, right? This is going to decrease osteoclast activity. And this is still controversial, but estrogen replacement therapy, because there's a lot of bad things with it, and there's no FDA-approved reason for that. So I want to ask you about that one. Yeah?
You know that
Well, right. Because you're only given Depo-Provera, which is progesterone. There's no estrogen in it. So what happens is they counteract each other, and progesterone goes higher, and your estrogen goes down. So yes, Depo-Provera shot, which is a birth control shot. One shot every 3 months, and you get pregnant. A lot of times you don't get your period either. But yeah. Okay. So questions on osteoporosis and osteopenia? Okay. So let me do congenital bone disorders. Okay? Dwarfism. Now we have something called achondroplasia. All right, this is 70% of all dwarf cases. Now let's just break up the word. I would love it if you guys actually have medical terminology, but we'll work with it that you haven't. And I'll just put this together for you. Plasia, like dysplasia, hyperplasia, metaplasia. What do they all have to deal with? Growth. So plasia means growth. Chondro, chondrocyte, chondrosarcoma. What does chondro mean? Good, cartilage. And if there's ever an A or an AN, that means without. So now you put it together. Without growth of the cartilage, or without cartilage growth. That's what that means. Where they're talking about is the growth plate. You see, when we get this, I'll show you the picture again, right? So you have this bone, and you have the growth plate over here, which, like I said, are all chondrocytes. This fuses and doesn't go through mitosis at about 21 years old. That's when you stop growing, right? I mean, it slows down like about 16, 17, but it stops. It fuses at about 21 years old. Well, in achondroplasia, it fuses at like 2 years old. Or it starts slowing down at 2 years old, but then it stops at 13. Or it stops at 10 or 8. Now this is only in the long bones, and that's key. Because that's where the growth plate is in the long bones. So what happens here is that their long bones stop growing, but the rest of their bones continue to grow adult size. So their long bones, which is in their arms and their fingers and their legs and their toes, stop. So these are people that have short legs, short arms, stubby fingers. Long bones are in your fingers. But they have an adult head and adult trunk. That's what they look like. They're out of proportion. All right? Then we have pituitary dwarfism. This is where growth hormone is not coming out in an adequate level. And it comes out of your anterior pituitary gland. Well, where does growth hormone go? Every cell in your body. It goes to your thyroid, your heart, your eye, your hand, your bones, your skin, your muscle. So what happens is when you don't have growth hormone, then nothing grows properly. So these are short people, but they are in proportion. Their head goes with the size of their arms and so forth. See the difference? Let's look at them. This is achondroplasia. Notice that the head is the same size as an adult head. The torso is the same size, but the arms, the fingers are stubby. The short legs here. This guy from, the Game of Thrones, right? Yeah, he's got achondroplasia. Short, stubby fingers, but his head is the same size as an adult. His torso, or his trunk, is the same size as an adult. Does that make sense? Okay? Now let's talk about pituitary dwarfism. See, little guy, right? Little person. But I know people say he's cute, right? But he's 50 years old.
Oh my God.
You know, that's what happens. Stop growing. That's it. But what I want you to see is his head is proportion of his arms as his fingers. You can see that, right? That's why I can look at people. I already have an idea of what's going on with people. Not that I want to, but what's that?
He just doesn't grow.
He just, yeah, everything. His heart is the same size as, so his heart can actually give blood to, because it's in proportion to the rest of his body. It's just a little person. Does that make sense?
He has like a normal size heart
For him,
Oh,
for that
okay.
size, not the same. Now, what happens is, age-wise, the heart is with a 50-year-old, but the size of it is still with a 4-year-old.
Okay.
Does that make sense?
Will they both live like an average?
As long as the heart and lungs are not compromised. There's different types of achondroplasia that affect other things also. But yeah, they could live to a ripe old age of 100.
How common is it?
I don't know the actual. I don't know how common it is. I know that achondroplasia is usually 70% of all dwarfism. There's a lot of subtypes of this. Okay, and it's a genetic thing also. Okay, questions? All right, so let's talk about osteopetrosis. Okay, this is also marble bone disease. What this is, and what happens here is there's defective or absent osteoclasts. You're already getting a picture. If you know what osteoclasts are, then you're already getting a picture of what may be occurring in this person. If they don't have osteoclasts, they have osteoblasts, well then the osteoblast activity is going to be excessive. Because no one is telling osteoblasts not to get to tone down, right? Because osteoclasts and osteoblasts, they work together. Okay? So they get dense sclerotic bones, similar to what we saw with Paget's disease, sclerosis. They get scarred. So you're going to have a lot of fractures also with this. All right? Now, the other thing too, if the osteoclasts are abnormal, then what's going to happen is the bone marrow is going to be filled with these abnormal, non-functioning osteoclasts, and they're going to overcrowd the bone marrow so much that red blood cells can't be made there. They have no place to make, or to be made, because the osteoclasts are just occupying all the space there. So now a lot of times people with marble bone disease, they're anemic because their bodies can't produce, it can produce red blood cells, it's just where you're going to put them because the osteoclast is just overwhelming and overcrowding the bone marrow. Also, the foramina, the holes in the skulls. If you have a lot of osteoblastic activity, they start closing up the holes. And if that's where cerebral spinal fluid is going out, now the cerebral spinal fluid is going to stay in the brain, and what's going to happen is you're going to have what we call hydrocephaly, where the brain gets bigger and bigger and bigger, filled with fluid inside. We'll show you that when we get into the nervous system. Okay? Treatment, we don't have much for treatment. There is bone marrow transplant, not 100%, but it may help to clear out those osteoclasts so that bone blood can be formed there. Okay? Questions on that? All right, so let's talk about bone infections. Okay. Osteomyelitis. Osteomyelitis is that the bacteria is going inside the bone, and what we're afraid of is after it goes in the bone, it goes into your blood, and then you got septicemia. That's what we don't want. There's a lot of reasons that can happen for this. The bone can crush. Let me give you a typical one, a diabetic foot. Okay? So you have a diabetic's toe. Not a good toe, is it? We'll talk about clubbing. This is not clubbing. Diabetic's not clubbing. All right. This. This. And really cut it well. All right. So this is what's going to happen. People with diabetes, they have a lot of glucose. We'll talk about that when we get to the endocrine system. But there's a lot of glucose that starts getting sticky. Okay, when the blood is filled with a lot of this glucose, it gets sticky and it starts clogging up certain blood vessels. We call it microcirculation. This very, very small capillaries, they clog up first. And what happens is these capillaries, since they're so small, those are the ones that actually feed into the nerves. Because nerves are tissue, and nerves need nutrition. They need oxygen, and they need glucose, and so forth. But if it gets closed, if it gets occluded, now you can't get the glucose and all the nutrients to that nerve. So the nerve dies. Right? That makes sense? If the nerve dies, and this happens in diabetics in the furthest place, usually first, away from the heart, which happens to be the toes, okay, the feet, they don't have feeling in their feet because the nerves are shocked, because of all this microcirculation that's being clogged. So they don't feel things. And a lot of times, you can see the diabetics, my father's diabetic, and I'm going to exaggerate a little bit, but the way they walk, they usually have a pot belly, all right, that's diabetics type 2, and it's pot belly, so they don't see their feet, so they can't tie shoes, they rather have just slip-ons, like slippers or something, and they usually will stomp their feet. Not so much, but I mean, that's the way they walk, right? They walk like this. The reason why they walk like this is because they don't feel the floor. I mean, they feel the floor, the pressure, but they don't feel like texture. They can't tell if it's rubbed, they can't tell if it's smooth like a hardwood floor, and sometimes they just can't, if it's really bad, they really can't feel the pressure there. So they stomp on the floor to make sure the floor is there where it is. You know what I'm saying? So they walk that way. People are nodding their heads like, yeah, my mom's doing that. That's what they do. Now, they could actually step on a piece of glass and not know that the glass went into their toe. no feeling there. So now we got a problem, okay? Or if they can go down and they clip their toenails, well, what if they have an ingrown toenail? They didn't cut it in a proper way. Now the ingrown toenail goes in the toe and starts getting infected. They don't feel that though. So what's going to happen here is that you have this ingrown toenail and you have all this bacteria that is able to go inside the bone. If it goes further into the deeper tissues, it eventually goes into muscle and then bone. If it goes into the bone, it's now going to go into the bloodstream, and now you're septic. This will turn all gangrene, and the only thing we can do, because if the bone is infected, we just have to amputate it so that it doesn't spread. That's what's happening with that. That's why a lot of diabetics, they have to go see their podiatrist. You know, sometimes once a week, once every 2 weeks, and they clip the toenails so it's done properly. They take care of it. They trim things down, they sand things down on the feet. They do everything but paint. All right? So, so the bacteria, the most common cause of this overall is Staph aureus. Okay? Just a few pointers. Sickle cell disease, think salmonella causing it. All right? It's a different one than what you eat salmonella poisoning. Tuberculosis. Yeah, it hits the lungs, but there's also one where if tuberculosis can go into the bone, it's called Pott's disease. If it goes into the bone, it can go into, you know, if the bacteria is leaving there, it can actually go into the bloodstream called sepsis. Okay? So the trajectory from bone goes to bone marrow. If it goes into the blood, it becomes septic. If someone is septic, not just for that reason, but sepsis is bad. I think it's the number 11 killer in America. Okay? So if someone's septic, they'll be intensive care, not a good survival rate. Okay? The treatment for this is that they're going to be on antibiotics, IV antibiotics, for 6 weeks. So yes, you get them out, you know, they get their toe amputated for 2 weeks, whatever, they're in the hospital, everything is now stable, they go home, but they have to come back to the hospital or doctor's office, and they have to continue getting the IV antibiotics for 6 weeks every day. So insurance have to get involved with this whole thing. Okay? So questions about osteomyelitis? All right, is that good? All right, so let's do Lyme disease, and I think that's where I'll quit with you guys.
I'd like to do a test review.
Yeah, I'll do that. Yeah, I'll do that. All right, but I want to be in the same spot as the other class. Okay, so Lyme disease. All right, so bacteria infection. All right, basically it's caused by the spirochete. All right, the little twisted kind of bacteria, and it spreads from rodents to humans by our wonderful deer tick. So we see a lot of it over here. You go to Kansas, it's very rare. Ohio, it's very rare because we have wooded areas around here. Okay. The symptoms vary. Okay. There could be this classic bullseye rash. And I'll show you what that looks like. It's called erythema migraine. Now, it doesn't mean they don't have to have this. And that's what's key. A lot of people think, oh, you have to have this. No. Secondly, you don't even have to see it. It might be on your back. How often do you look at your back? It only lasts for a couple weeks, too. So it could go away. All right? You get fevers, fatigue, joint pain. So look at this. Fevers, fatigue, joint pain. I mean, that's symptoms of taking my pathophysiology course. You know what I'm saying? So what I'm saying is Lyme disease is a great mimic of a lot of different diseases. If you're thinking of joint pain and fatigue, and you've been in a wooded area, you know, in the past like month or so, I mean, I'm not saying you have Lyme disease, but make sure that's in the differential diagnosis, okay? Because it's easy to fix. You just get antibiotics and you're done. But if it goes further, it can cause problems, all right? We don't want it to go to the brain. We don't want to go to the heart. So treating early is vital to do this, okay? And just antibiotics to do that. So this is that little bullseye kind of thing. And it's pretty classic. You just see it like this. But again, I'm not looking at my back, right? So you don't know if you have it there or not. And it doesn't itch. So it's just something you have to see. Okay? And that's the little guy. It's not him, it's what he carries. I mean, if you get bit by this, that's fine. Not that he would. It's getting bit by this thing. And these, you don't even feel. I'm from Jersey. We live in the mountains. I've had these on me walking my dog in the woods. You don't even realize it's on you. I'm like taking before I take a shower, I say, what's that black thing? And I notice there's legs on it. You gotta take the thing off. You don't even realize it. But they don't hurt, they don't itch. It's pretty common. You don't realize that. All right? But you have to be careful how to remove these things, because you can remove it, but if the mouth is still clinging, that's where the bacteria is. So there's a little way, you have these tools that you just slide right off. They're easy to take off, but having a tool works out. Okay? But that's where we are. Look, New Jersey, Massachusetts, hey, it's all right there. Go in these areas, you just don't see it. Okay? You just don't see it there. All right? They have all these different alerts to do and how to take them off.